Hi, my name is Rodney Comisar. I'm an orthopedic surgeon at OrthoNeuro. I specialize in treatment of problems associated with the shoulder and the knee, as well as sports medicine. I'm going to talk a little bit about shoulder pain and more specifically shoulder arthritis. Shoulder arthritis is one common cause of shoulder pain, especially as our patients get older. And older is a relative term, certainly nowadays, as I'm in my 50s. Rotator cuff problems are overwhelmingly the most common issue we see in the shoulder, with shoulder arthritis a close second. Shoulder arthritis can present in many forms. Typically, patients will have pain, often localized to the lateral or posterior aspect of their shoulder, which may be a little different than rotator cuff pain, which is more anterior. In addition to pain, these patients will often complain of stiffness or loss of movement, meaning they can't move the shoulder, and often also we have trouble moving their shoulder due to limited range of motion that can occur as a result of the arthritis. Patients may complain of popping or grinding in the shoulder, although that can also be manifest in other conditions such as bursitis. Lastly, a most common complaint I hear is night pain, which is often what will bring someone into the office saying, I can't sleep anymore. I can't lie on my side. Sometimes even lying on their back or the opposite shoulder can be problematic. Certainly this is not unique to shoulder arthritis, but is a common complaint we see with arthritis. The most common is certainly what they term the garden variety osteoarthritis, or quote, wear and tear. It refers to just deterioration of the joint, or the articular cartilage or the coating cartilage on the ball and socket joint deteriorates or thins to the point where you get the quote bone on bone condition. With this, bone spurs are formed and often leads to that stiffness condition that goes along with the pain and the grinding. Secondly, rheumatoid arthritis, which is more of an inflammatory condition where the body essentially almost attacks itself. It's referred to as an autoimmune disease. This works a little bit differently, where the lining of the joint or the synovium gets inflamed and then produces enzymes that lead to the deterioration of the joint. Some of those patients also will get stiffness, but their arthritis pattern's a little different, but same kind of results and symptoms can occur, certainly. Another type of arthritis is post-traumatic arthritis, meaning after a fall or an injury. Sometimes it can be associated with a fracture or a broken bone around the shoulder, primarily what we term the proximal humerus. Sometimes those fractures can injure the blood supply to the humeral head or the ball part of the joint and result in deterioration over time, where that can develop arthritis in the patient, sometimes relatively quickly, and then sometimes more, over years or decades even. Another type of arthritis we see is associated with a different blood flow problem called avascular necrosis. The blood supply to the humeral head specifically can be disrupted. Again, can happen after trauma. Certain conditions such as sickle cell disease, lupus, in some cases patients with alcohol abuse or excessive use. Also in rare cases, people that dive or scuba dive. What happens is the blood supply is disrupted to the head, the bone cells die, and then the head ultimately collapses. So it can start on the humeral side or the ball side, and then ultimately can affect the socket if the disease progresses or advances enough. The last type of arthritis we term rotator cuff tear arthropathy. Certainly rotator cuff tears, as we commented on earlier, is very prevalent. Larger tears can actually disrupt the function of the shoulder, the ball and socket joint, enough to where the head will migrate superiorly. That superior rotator cuff is not depressing the head, if you will. And as the head migrates, it can change the mechanics of the shoulder enough to where the patients can't elevate their arm and they may do this instead of this. And that's termed rotator cuff tear arthropathy, to the point where the joint can also be involved. The cartilage can deteriorate and even kind of wear the joint asymmetrically to the point where the patient can develop arthritis as well. This is treated a little bit different sometimes than classic shoulder arthritis, which we can get into later. We recommend patients coming in to visit the office to have their shoulder pain assessed really when it starts to affect their quality of life. When you have pain that affects your daily activities, pain that affects your sleep in particular, we see that quite a bit. Certainly functionally, when you lose range of motion to do your activities of daily living or profession in some cases. And lastly, strength. Strength changes are not as consistently present with shoulder arthritis, but can be, especially in those rotator cuff tear arthropathy patients. So how do you treat shoulder arthritis? Certainly there are surgical options that are very good and reproducible as far as helping pain, improving function, and improving strength. However, certainly most patients aren't ready to jump right into surgery, and we understand that, nor do they necessarily need it. Changing your activities to kind of find your safe zone is advisable. I recommend patients kind of keeping stuff or activities below chest level, maybe closer to their body. It becomes more difficult to work away from your body, overhead or behind you. Icing can help better than heat. Sometimes sleep-wise, it's better to sleep propped up rather than laying on your back or on your sides. It becomes more difficult to get good rest that way when you have these conditions. Anti-inflammatories can be used if they're medically indicated. Certain patients, as they get older, have more restrictions on their ability to take anti-inflammatories. They may have heart trouble, they may have bleeding issues or be on blood thinners, which we have to be aware of and consider those when we're medicating our patients. Certainly Tylenol is safe. We tend to try to avoid giving patients narcotics for these conditions just because we think they're better served with either other types of conservative care or in some cases surgery. Occasionally over-the-counter sleep aids can help these patients as well. It becomes difficult to do therapy because sometimes it actually makes them worse. So I'm sensitive to that. If we catch them early on, we can do therapy to help with range of motion, as well as maintaining like the core strength around the shoulder to try to extend the life of the joint. In some cases, we'll use steroid or cortisone injections. It can kind of calm the joint down. It's kind of like putting out the fire, so to speak. I find it can help sometimes gain range of motion, help pain, as well as help the patient sleep. It really doesn't fix the problem, and you have to be careful. You don't want to get into a cascade of doing that too frequently. Eventually, I find those injections will stop working. Another option I've used in the past is viscous supplementation. It's something that's used in the knee quite frequently and with reasonable results. In the shoulder, it's considered off-label, so typically it's not something that patients can get through their insurance. They can pay out of pocket. There's not a lot of evidence in the literature that works. However, in my personal experience, I've used some over the years at times with patients looking for alternative options and have found that to be helpful in the majority of cases. Other options on the horizon that we're beginning to try to understand better are stem cells and PRP injections to provide relief. Again, we think it's more symptom relief than actually reversing the disease process. Physical therapy can be helpful in these patients, especially if we catch them early in their symptom stages. I think it can help range of motion and maintain that by showing them some stretches, as well as help them with strengthening exercises that can be improve the core strength of their shoulder without irritating the joint. Certainly heavier weights, things away from your body and overhead is more difficult. I find patients with more advanced arthritis don't tolerate the therapy well, and in fact, in some cases will actually exacerbate their symptoms and lead to worsening of their pain.